We saw some really interesting data at ASCO just a few months ago from the TIGER studies. These were studies of ruxolitinib, a third-generation EGFR TKI that's no longer being developed, but all the same, we learned some interesting lessons from the biocorrelates on that study, on those studies. And so what they did in these studies was they were looking for T790M, and they looked for it in tissue, plasma, and in blood. Tissue, plasma, and in urine. And these results were not always concordant. There were some patients that were positive in all three modalities, some patients for whom their test result was negative in all three modalities, some that it was found in only one, and some that it was found in any two of the three. Regardless of the way that T790M was found, the response rates were all just about the same. It was also interesting in that data set that patients who had distant metastatic spread outside of the lung, stage 4B disease, were more likely to have results found in urine or blood than patients that had intrathoracic spread only. You cannot action a molecular change unless you find it. And so every non-squamous case of stage 4 disease deserves molecular testing. If an EGFR mutation is found, the standard of care is an EGFR TKI. There are three that are FDA approved in the US: gefitinib, erlotinib, and afatinib. All three of these agents have been compared head-to-head against cytotoxic doublet therapy in the first line. I think the experiment's now been done about 14 times, and every time the result is pretty much the same, which is that progression-free survival is notably better with the EGFR TKI for the patient with EGFR mutation, and toxicity of the targeted therapy is lower than chemotherapy. Erlotinib alone has been compared to erlotinib plus bevacizumab in a randomized phase 2 Japanese trial for the treatment of metastatic stage 4 EGFR mutated non-small cell lung cancer, and the addition of bevacizumab did seem to help significantly. These results are being further evaluated in a US trial that has recently completed accrual, and we await data on it. It is not an FDA-approved option, the addition of bevacizumab to erlotinib, but I would consider it a controversial but reasonable thing to consider in clinical practice. Gefitinib has a really interesting story. The IPASS study, which compared gefitinib to carboplatin plus paclitaxel in unselected patients, was the first to really bring out this EGFR story. Later subgroup analysis of that unselected trial showed us that for patients with the EGFR mutation, that the TKI was much better in first line, and that for patients without the mutation, that chemotherapy was much better in the first line. However, gefitinib lost its approval in the US due to a failure of efficacy in unselected populations, populations without the EGFR mutation. Based on some more recent data, gefitinib has now regained its approval in the US, and so this question again becomes relevant of when gefitinib should be used. Gefitinib is a less toxic agent than erlotinib and afatinib. In particular, there is less rash and less diarrhea, and for patients who want to avoid these side effects, I do consider it a preferred agent, and it is one that I use frequently in my practice. Afatinib is a second-generation EGFR tyrosine kinase inhibitor. It binds EGFR irreversibly, unlike the first-generation agents, and it also takes out HER2. Recent trial results have compared afatinib to first-generation TKI and showed a longer PFS, but that longer PFS came at the expense of greater toxicity, particularly in the form of the classic side effects of rash and diarrhea. And so I think for the very motivated patient who can tolerate that additional toxicity, who's not frail, who is more motivated to longer disease control as opposed to toxicity avoidance, afatinib can be a preferred option. I think we're awaiting survival data from that trial to determine how mandatory the switch might be.